All right, why don't we go ahead and begin? My name is Glen Elliott. I am Chief Psychiatrist and Medical Director here at Children's Health Council. I want to welcome you all for coming. I'm mostly here to kibitz. Dr. Anderson gave me permission to throw in comments occasionally, but we have the pleasure of having a visitor from New York who has been here for about 3 or 4 days and actually I think done more talks than he's been here days. So I've had the pleasure of listening to him 2 days ago. I think you will find it a very useful evening. Dr. Anderson is Senior Director of ADHD and Behavioral Disorders Center and the Director of Programs at the Child Mind Institute, which is located in New York City. He specializes in evaluating and treating children and adolescents with ADHD, behavior, anxiety, and mood disorders. Expertise includes behavioral parent training, school-based consultation, behavioral support, and cognitive behavioral therapy. He also directs school-based programs, then provides workshops for has provided workshops for more than 800 parents and nearly 3,000 educators, while also delivering interventions and social emotional skill building groups for more than 6,000 students. Dr. Anderson frequently lectures and leads workshops for policymakers, parents, and educators, and also contributes to media and mental health outreach efforts for organizations such as ABC, Time, CBS, Fox, NBC, Wall Street Journal, Atlantic, New York Times, and NPR. He received his bachelor's degree from Dartmouth College and then found what appears to be home in New York City when he became a doctorate in clinical psychology at Columbia University. Dr. Anderson?
Hey, folks. So, just a quick word about where I'm coming from. So this is the Child Mind Institute. That's our entrance right there at 56th and Park. In general, the work that I do, Glenn already gave more than enough biography. But what we do is we do 3 things. We do clinical care, we do research, and then we also do public education and outreach. So the reason why we list all those media organizations there is that I spend a good 30 to 50% of my time talking to parent groups like yourselves, talking to educators, or doing TV stuff or print media related to child and adolescent mental health. Our mission is to get evidence-based information about child and adolescent mental health to the populace. Now that's a mission that's also shared in part with organizations like CHC and partners around the country. But this is why we end up deciding to do talks like this, is that we hope that when you leave tonight, you have a better science-based understanding of ADHD, how you might support kids that you know or within your family, or adults that you know with ADHD, and what next steps you might take. So, with that, I'm going to start with just a warm-up where I'd like to hear from you all what you're hoping to get out of this workshop tonight. What I'm going to mainly do in the slides is talk about first how we diagnose and treat ADHD and behavior disorders, then move into the strategies that we use at kind of a 3,000-foot view for ADHD and behavioral symptoms, and then try to apply those strategies to any questions you might have related to kids that you might know, or questions you might have about people who have difficulties with attentional or behavioral symptoms. I've brought case studies that I can talk about, but I don't usually talk about them. I also don't usually get through all the slides, partly because I would like this to be somewhat interactive. I build it in so that it's something where I can talk if an audience is entirely, free of questions, but that just doesn't happen. People arrive here because they're interested and they're bought into the topic. So with that, in terms of the warm-up, tell me about some of the questions you hope to get answered tonight. Go. Yes?
Two I was thinking of. One is the effects on sleep, and then also strategies, interventions for that impulsive behavior of just not thinking, not stopping, not breathing, but just impulsively acting out.
Got it. So we will definitely get into strategies for impulsive behaviors or how you act out, those kinds of things, and behavioral strategies you can use. What I will say is that I'm not going to talk too much about sleep tonight. One of the slides that I have talks about how in any diagnostic evaluation, what we're trying to do is rule out anything which may exacerbate ADHD symptoms. So the note on sleep that's pretty important is that when we do intakes for any particular patient, we usually go through a number of medical or developmental issues that might affect ADHD symptoms. The reality is this: a lack of sleep doesn't necessarily cause ADHD. I want to be clear about that. However, for any human being, if you don't get sleep, it generally makes mental illness worse. So what we try to check for is that if we know that A, kids with ADHD and adolescents with ADHD are more likely to have disordered sleep, and B, that if they're not getting sleep, even if they don't have disordered sleep, it may exacerbate attentional symptoms, we want to ask parents about that in order to be able to assess how severe symptoms actually are. Because our first-line intervention related to sleep, for some families, may be to get a kid better sleep hygiene and on a better sleep schedule in order to really assess the prevalence of ADHD symptoms before we proceed with intervention, especially if parents are trepidatious for any reason about medication, which again, with Glen in the room and not being a psychiatrist, I'll say we are not opposed in any way to utilizing medication. It is one of the frontline treatments for ADHD. It's just that for most families, we're looking at it as something where we want to rule out all other variables prior to instituting intervention like that. Other questions? Yeah.
Yeah, it was along the lines of medicine in terms of if we're on the fence, like I'm sure many parents get to this point of do we medicate our kid or not, what would be the few things that you would recommend that to get you either over the fence or stay on the side of the fence of not medicating kids?
Right, so I'm not going to talk about medication too much tonight because I'm a psychologist and I don't prescribe medication. But what I will tell you is that very few families have actually had a conversation about medication with a child or adolescent psychiatrist like Dr. Glen Elliott over here. So the reality is they've gotten most of the messaging from either other parents or from media stories, which tend to be fairly sensational and anecdotal. You know, I have family members on stimulant medication for ADHD, friends on stimulant medication for ADHD, and many patients on stimulant medication for ADHD. The reality is that these things are safe and effective when monitored by a child and adolescent psychiatrist. The side effects tend to be mild and predictable, and the medication tends to be effective at a rate that is fairly high, in the 70s to 80%. So what we're talking about is something where we often look at cautiously at young kids and medication, partly because we can't necessarily get reliable reports related to side effects, or there's evidence that the medication may affect those children somewhat differently in terms of side effects. But these are things that we proceed with in terms of a frontline intervention for ADHD, and I'll talk about that in a second. Glenn, do you have anything you want to add?
The other thing that you do is to think about what else the other options are.
Totally.
And part of the answer is if those other options aren't working.
Right. Because what the CDC recommends is that for kids under age 7, you start with the psychosocial interventions that I do in my treatments, and then they'll also outline here. And the reason they outline that is not because of a lack of safety around medication. It's because of rampant misdiagnosis at younger ages, and it's also because psychosocial interventions work at a level that is parallel to medications in longitudinal studies. The only issue is psychosocial interventions are a hell of a lot more work than medication is. You give a pill, and within 30 minutes, you see a decrease in ADHD symptoms, that lasts for a good period of the day. Psychosocial interventions require adults to change their behavior in order to get better behavior from a kid with ADHD and behavior disorders. And those interventions tend to take 12 to 20 weeks to be effective, and they tend to need significant behavioral change on the part of the adults in a child's environment in order to be effective. The reality is that we also have sequencing literature where what's been shown is that parents who start with psychosocial interventions and then add medication later on have better outcomes. This is Bill Pelham down at FIU, have better outcomes than those who start with medication and then add psychosocial interventions, which is why a lot of people end up in my office first, for most reasons. Yeah.
Differences between girls and boys and diagnosis.
God, these are good questions, none of which I have on my slides, so I'll just keep like spitballing with you. So the girls and boys thing, when we look at ADHD prevalence and diagnosis, the reality is that we believe that boys are 2 times more likely to have ADHD than girls, but in clinical settings, boys present 3 times more often than girls. One of the reasons for this is about gender roles and the presentation of symptoms. So Steve Hinshaw, who's out here at UCSF, has written a lot about this. When you look at symptoms between girls and boys, frequently what happens is that since boys can present more with the combined presentation of ADHD, which includes hyperactive and impulsive symptoms, they will tend to be clinically referred more often because those symptoms are more annoying to adults. They can't sit down, they can't stop talking, they're impulsive, they're calling out, everybody wants that kid to get a referral. Because girls tend to present more often with the inattentive presentation, that can mean that for one reason or another, adults in a girl's environment will say you must be anxious or you must be depressed. That's why you can't pay attention. Now, to be sure, not being able to pay attention is something that is correlated with anxiety. It's correlated with depression. It's correlated with PTSD. So there's definitely the possibility that that's an explanation for symptoms. It's just that girls, as the research shows, tend to get overlooked when they have ADHD because the thought is that it's not gender conforming, that girls must instead be internalizers, not externalizers. So the issue is that if we see a girl for whom someone is reporting that they have difficulties with attention, we are often telling parents, please trust them if they're telling you they're not depressed and they're not anxious. It may actually be something biologically based like ADHD, and we want to get them treatment. Another thing that is, this is the thing, in terms of outcomes related to ADHD, there's some emerging evidence of differing outcomes between boys and girls around ADHD. Do you want?
Hinshaw's
Yeah, exactly.
talked about
Yeah.
that. It's mostly about, so it breaks down to exactly what you just said.
Yeah.
Boys tend to be doing things externally, getting themselves in trouble. Girls tend to be internalizing self-injury,
That.
eating disorders,
Right.
depression, anxiety.
And that's where Steve will even say that it's something that he has not seen replicated outside of his own research, but this was a study that was done with thousands of patients. And so for that reason, we can trust that some of those effects are really there. What were you going to say?
My son heard from a professional, at least his interpretation was that he would never be able to read effectively.
Related to an ADHD diagnosis, not a dyslexia diagnosis or reading disorder?
No, ADHD.
Okay, I'm sorry that that professional exists. Right.
Exactly.
Yeah.
And she recounted on that and actually did
Good.
decent repair work.
Yeah,
But the reality of is that reading for him will always be hard.
right.
And so strategy.
So that's not a symptom of ADHD, importantly. If a child has difficulty with reading, that does not necessarily in any way correlate with ADHD. Academic difficulties are not a symptom. So let's get to the root of it, which is you're asking about reading issues.
Reading issues.
Right.
Comprehension.
Yeah.
Yeah.
So what kind of support is your child getting around reading?
Well, he heard from multiple professionals that medication was the right way to go. And so
Okay.
he'd seen an executive coach. Executive coach gave him strategies. In today's world, he felt like he already had access to those strategies because he could look up on YouTube, strategies for ADHD.
Right.
And within 5 minutes of a trial, he would say, this is not working for me. And so whether it was different styles of reading, rapping while he was reading to get rhythm when he was reading, trying to highlight, underline, annotate, things like that. But again, he's someone who
Right.
tends to not have the grit to stick to something.
Right.
And so he's just been moving from trial to trial to trial to trial without sticking with anything and really
Yeah.
improving his skills.
So getting away from questions of us parsing, which I think we can sidebar later about what the actual difficulty that the professionals are telling you your son has. Here's the thing, when we talk about grit or persistence, the techniques that I talk about in these slides related to how parents support that are the key. For a kid with ADHD, it's actually an expectation that's entirely illogical to expect that they will be able to independently apply strategies that they're learning from other adults. What we tend to do is create behavioral systems that hold those children accountable in practicing those strategies in a supportive way. Because what ends up happening is follow-through and execution is one of the biggest deficits in ADHD. So even though you might have 100% commitment and you might be so excited to apply a strategy and so excited to have this success that you get from this rap video online, related to ADHD symptoms, it's not something that you see persistence on unless we teach adults how to help foster that persistence. We're going to get into that.
Yes. So I have a young son who has moderate to severe ADHD, and like many days, I feel like that I need to have one constant person to be just monitor his every behavior. Otherwise, we cannot get anything done. And do I need to do that? Is that my way out? Is that my only way out?
That's a highly loaded question right there. The answer is, look, we're going to talk about the defining principles for that person. So one of the things that we say a lot within the center that I run in New York is that there are no unicorns. People who are good at structuring a kid with ADHD's time, effort, or organization are not doing something magical. It's just that oftentimes they've been doing something naturally that we know works for kids with ADHD, and we need to be able to operationalize that for every adult in the environment. So it isn't that you have one person sitting next to your child at all times. It's more that we help make sure that each adult that's coming into contact knows what the game plan is and can help to foster that kid's progress. You also have on the ball and off the ball times. So what we expect is that your son should have certain things that need to get done and certain moments of leisure throughout the day. And what we hope to be able to do is define different parameters for those moments so that then we're able to get the effectiveness in sprints and then allow the child to relax in other moments. So I'm going to get into the slides in just a second, but yes.
Yeah, so I'll try to keep the question general.
Hey.
I have a daughter with 12-year-old with ADHD inattentive. Absurd lack of focus, and I'm willing to do everything I can to get her through school with her self-esteem intact.
Right.
That's a big issue.
Yeah.
Is just trying to make sure, and she's also dyslexic.
Absolutely.
So I'm trying to see the future and know whether or not, I know every child is different, but I want her to go to college. She's not going to have me there making her lists and helping her check them off and giving her reminders. And so our kids with ADHD, I'm not likely to medicate her, likely to get better as they move into their late teens and adulthood.
No, not without support.
They just need systems at that point.
Well, the reality is this. If they get good support and intervention, they're likely to get better. But ADHD is a lifelong condition. The symptoms are managed. 75% of people diagnosed with a condition retain those symptoms at a clinical level into adulthood. The other 25%, it tends to be subclinical. It doesn't go away. But when we say that people would get better, it's that as kids get older, the interventions that we utilize place a larger locus of responsibility on the child. So under age 10, we tell parents the locus of responsibility is on the adults in that child's environment to be their prefrontal cortex. As the kid gets older, as you move into the junior high years, you might get some overlap. As you move into high school, our job is to start figuring out how to bring that responsibility into the teenagers' kind of level of responsibility. And as we get to college, it's helping them. I mean, just before I came over here, I was doing a FaceTime session with a college student that I still coach today in 30-minute bursts twice a week while he's at college right now. He's a freshman in college. And what we do is we run through drills that are well known to this kid, but for which he needs some level of support. So he's sitting there and he said, I was sick on Monday, so I asked my professor for an extension for 2 days, for this video project that I've got to do. And I said, great, so you asked for an extension. Did the professor grant it? No, she hasn't responded to my email yet. So what are you doing to ensure that your email is responded to? Well, the project still isn't due for another 2 days. I just asked for another 2 days beyond that because of my sickness. And I said, you preemptively asked for 2 days of extension? And he said, well, I really was saving it for the last minute. And I said, okay, we're making an action plan right now that I'm going to email you, and you're going to text me, reminders that you're getting this done. The reality was, when we got into the project, he'd already filmed a number of his scenes for the video. He'd already gotten some of the editing done. He'd familiarized himself with the editing software. It's just that he hadn't marked out his timeline exactly like he needed it to, and he didn't have the boxes that he needed to check. For a lot of students today, as they go to college, there are those support services on every college campus. We just have to make it so the kids feel a lower level of stigma, a lower level of shame, and feel like their job is to walk onto their college campus, to be a college student, but to advocate for the support services they need the moment that they arrive there, or continue to use the people at home, and to figure out how to use telehealth in a way that kind of supports them. Were you going to say something?
Yeah, I wouldn't completely rule out medication. My son also had, fortunately didn't have a
You okay?
disorder. He definitely has independent ADHD, has done very well. He waited until he got into medical school before using medication, which was not my choice, but that's what he decided to do.
Mm-hmm.
He's really found medication to be really quite helpful now as a 33-year-old adult. I completely agree with everything that was just said. This is the neat thing about growing older is your brain develops mechanisms that it doesn't have
Right.
now.
And most adults with ADHD, even when they're untreated, will develop their own workarounds. It's just that those workarounds may be closer to what we know, to what works in a scientific evidence base, and then they may be ones that are a little bit less effective. The reality is that untreated ADHD leads to an increased number of automobile accidents, an increased number of relationship breakups and divorces, difficulty following through on jobs and job transitions. So what we're looking for is to help people to be more aware of what they need and how to support themselves as they grow older. I'm going to take one last hand, and then I'm going to start on the slides. Yeah.
Great. I have an 8-year-old boy, and he has hyperactivity and impulsivity. Are there things that happen in puberty, like that are just going to throw us for a loop that maybe...
Regardless of whether or not your
Yes.
8-year-old boy has hyperactivity and impulsivity. Yeah.
With reference to ADHD, so we're going to see, excessive risk-taking behaviour, a propensity for drugs, more so than other teenagers.
So
Kind of question. And the second question is, There's some great things about ADHD, I think, in terms of the way his brain works. Are there affinities in areas of work that he should strive for to like maybe leverage some of this stuff as a strength?
So I'll hit the latter question first and the first question latter. The thing is with ADHD, and there's a slide that I have on this as well, it's a disorder of variability. It's that if you've got a task that's boring, repetitive, non-novel, or requires a lot of effort, that's where ADHD hits you. However, if you have a task that you're passionate about, that's novel, that's not repetitive, and that you don't find boring, lots of people with ADHD find that, you know, they are able either to focus or that they have more creative thinking around those particular things. And in many ways, that can kind of be an advantage. What we coach people to do with ADHD as they get older is to really seek out those passions and to seek out jobs that have the largest share of that they can possibly find. The issue is for some people that may not be a possibility, and for that reason then we help them to focus on, you know, doing well at the non-novel, repetitive, or boring. But what will end up happening as people move on in their careers is oftentimes they'll self-select into fields where their ADHD symptoms have less of an impact and where their strengths can really shine. In terms of puberty, untreated ADHD has all of those negative effects that you're talking about. So if you do, and this is the thing, untreated mental illness has those effects. If you have untreated anxiety, untreated depression, you have more of a chance of risky behavior in adolescence, more of a chance of substance use, partly because of self-medication for a world that's rejected you and said you're not successful for reasons that are due to the fact that you just are terrible. Like, what teenagers do is when they're not treated, they interpret their symptoms as being what we call egosyntonic. They decide then that the world has kind of rejected them, and the biggest risk factors for substance use don't tend to be treated ADHD. It tends to be academic failure, tends to be family rejection, social rejection, things that come as kind of added difficulties with untreated mental illness. One of the things that I think we cite frequently is that kids who are well treated for ADHD are no more or less likely to use substances than their peers. Now, I wish it was less likely, you know, but actually it's just that well treated ADHD means they're normal. They're just no more or less likely than their peers to use substances. Okay, so I'm going to go into a couple of these slides kind of looking at the diagnosis and treatment of ADHD, because a few of your questions really relate to this, and we've kind of already talked about these topics. First, and this relates to the first question about sleep, it's that anytime we're looking at any mental health diagnosis, we're using a biopsychosocial model. So if we're being responsible about mental illness, it's that we're not asking just questions that confirm the symptoms that a parent or a grandparent or an uncle is already telling us as a family comes through the door. It's that we're looking at all these factors. What kinds of biological vulnerabilities a child has, what kinds of psychological factors are coming into play, what kinds of social factors are affecting these symptoms. So for example, ADHD's diagnostic criteria require that the symptoms be present in multiple settings for the diagnosis to be given. The reason is that ADHD is a biologically based condition of the frontal areas of the brain. If it doesn't present at school and at home, it may not be ADHD. If it presents only at home, like if we have a parent who comes in and says the child has difficulties focusing on homework at home and is only impulsive when we're out to dinner, interrupting us all the time, we commonly will start treating that as a parent-child relational problem or a problem of behavior rather than thinking that's ADHD, if when we go to the school they report nothing like it. And they say the kid is focused and that, in fact, they only make pertinent comments in class discussions. But there are major reasons to assess for every factor in a child's system before we make a diagnosis, just because there are so many things to rule out. One of the reasons why when we do an intake, we take 3 hours is that we're trying to get a sense of the child's history that is so complete that before we rule in any diagnosis, we've ruled out every other factor that might exacerbate symptoms or might be masquerading as the symptoms of this diagnosis. So this is a slide that I show. It's busy and it's difficult to read. It's a slide that I show to remind everyone that as much as I speak with white male confidence, we are not in the best of all possible worlds. So what that means is that science isn't perfect. Even ADHD right now is likely to have a different name. Like I think my center at the Child Mind Institute is going to be named something like the prefrontal disorder of the brain center, in 10 years, or maybe something less stigmatizing. But the reality is that as the science evolves, the names evolve, we get less stigmatizing, we get more exact, and our medicine gets more precise. But to be sure, what I'm speaking about so confidently is what works best right now. but we are not necessarily saying it works perfectly, and we're not saying it's the best treatment we're ever going to have, and we're not saying that we're going to be giving you a different talk 20 years from now. The reality is that ADHD started when Kraepelin first described it in 1798 as mental restlessness. Then it went into definitions in the 30s through the 80s that were quite stigmatizing. Minimal brain damage, minimal brain dysfunction, then hyperkinetic reaction of childhood. Only around 1994 did we move into the kind of presentations and subtypes that we now have today. Now the thing is, each of these iterations of the DSM is based on new and emerging research that's then taken into account by a large group of experts the world over who make decisions about what now comprise the diagnostic criteria. Now the thing is, ADD has not existed as a diagnosis since 1994. It's 24 years, hasn't existed. We still have parents who come in droves saying, my kid doesn't have ADHD, they have ADD. And that's because within our society, ADD still has a lower stigma than ADHD, because the hyperactive impulsive symptoms are considered so stigmatizing and possibly reason why a kid might be suspended or sent away from school. But ADHD became the dominant form of the diagnosis in 1994. Now, at that time, the thought was that there were 3 subtypes of ADHD. An inattentive subtype, which has the symptoms in the top kind of grouping here on the right, hyperactive impulsive subtype, and combined subtype, which has symptoms from both categories. And you need a certain number of these symptoms presenting for a certain amount of time with a certain amount of frequency across settings in order to get the diagnosis. The threshold is actually quite high. Now the problem with the subtypes was, even though in 1994 we clarified that it's ADHD, kind of with different subtypes, by 2013 what was clear from the research was that while ADHD as a diagnosis is reliable across development, the subtypes aren't. A kid can get diagnosed with a combined subtype at 7, they might be diagnosed with an attentive subtype at 12, and the problem was that was decreasing the confidence in the populace that this diagnosis exists. Not to mention that during the time between 1994 and 2013, there were many movements against psychiatric medicine from a host of kind of sources. So in 2013, it became ADHD with 3 symptom presentations. Because what we're trying to make sure that people understand is that somewhat like the flu, what we're trying to convey is that there's ADHD, which is reliable, but that you may have some of the symptoms of the flu that present at certain times and some symptoms that present at other times. And they may present differently. So in that sense, a kid's presentation of symptoms may change over time, but they will still have ADHD. So that's where we are right now in 2013. My guess is by 2020 or 2025 or 2026, we're going to see new names, possibly new presentations, and new and emerging science about brain disorders. Because one of the things that our research arm focuses on at Child Mind is that we're building a database of 10,000 children for whom we have hair, blood, saliva, baby teeth, all kinds of different biological markers. But our job in doing fMRI then and all kinds of different brain scans on these kids, and we've done about 1,700 right now, is that we release our data sets to the world. We release everything as a part of an open science initiative. So while we've published 40 some odd articles on our data, the world has published 400 some odd articles on our data, with us not included as authors. Because what we want to see is a breakthrough in our lifetimes. Our research head commonly has said to our president that open science is the way to make sure we're alive to see the actual discovery. If we don't share all of our data with the world, no one's probably going to figure out where the brain-based substrate is for ADHD. Now this relates to another point that I'll make. Anyone who tells you that they can give your child a brain scan and then they can diagnose ADHD based on it is a charlatan and they're a snake oil salesman. It's pseudoscience. And what a lot of these services do is they give you an evaluation that looks like the evaluation I'm about to talk about in 2 slides. Then they also give you a brain scan. And what research has shown is anytime you mention the brain, people believe you more. So that's what we end up with, is that somebody scans a kid's brain and everyone believes that that person is right. The other thing that these snake oil salesmen do, which is really scientifically irresponsible, is that they peddle both the cures that work for ADHD and the stuff that doesn't, but that also costs a lot of money. So they'll tell you, we're going to do a course of behavioral parent training, and we're going to put your child on Concerta. We're also going to give them B12, and we're going to give them some supplements you can only buy from us. The issue is those latter 2 things have no evidence of working for kids with ADHD, where the first 2 things are evidence-based practice. The problem is people can't throw the baby out with the bathwater. They think everything works together. And oftentimes, it's the thing that is the least invasive or the thing that they feel like is the most holistic that they'll latch on to, because it either requires less effort or it seems like it'd be less injurious. Holistic cures don't work for ADHD. We have no evidence they do. And I'll talk about that in a sec. So I've already kind of hit on this slide. The issue with ADHD diagnosis is that there is a lack of objective markers. You have to see a clinician and report certain behaviors in order to get the diagnosis. But that clinician has to be informed by where attentional and behavioral concerns can stem from so that they can rule out those other sources. Because we do not want to diagnose a kid with ADHD when in fact a kid who's experienced a trauma may also have difficulty focusing in class and at home, but that may be due to hypervigilance and re-experiencing, not the fact that they have difficulty focusing. So we want to be able to rule in and out everything. Now in terms of how we diagnose ADHD, this is the kind of evaluation on the left that we do to responsibly diagnose. We do a diagnostic interview in which we give a parent interview where we ask parents about their child's symptoms, both of ADHD or a behavior disorder, and of everything else. And we make sure that parents are both qualitatively reporting symptoms to us and filling out symptom questionnaires that have been normed on thousands of kids across the world to be able to compare them to normative groups of their peers. So we have the parent interview. Now, the important thing with ADHD is that child interviews are unreliable. So interviewing a child or a teenager with ADHD. First, young children tend to be unreliable in general. Like, I had a kid in my office a couple weeks ago who, in the same breath as he was telling me about his ADHD symptoms, was also telling me about how he killed a rat that had crawled into his study. There was no rat. He'd never killed it. He told me it was a ceremonial spear that his father had gotten him at a carnival that he used to kill the rat. When his parents came in and I told them this story, they sighed and they said, honestly, is lying a symptom of ADHD? And I said, no, he just has a nice imagination and he was fine. But, you know, the kid just loved the attention he was getting from the story of conquering the rat. Whoa. So the thing is, the other thing about teenagers is that when we do interviews with teenagers, many teenagers tend to be defensive because especially if they are presenting for treatment for the first time as a teenager, they are pissed off at their world. They've been told for 5 or 6 years, why can't you just try harder? Why aren't you focusing? Honestly, we made it clear. We've given you these directions 10,000 times. So when they walk into the therapist's office, what tends to happen is we say, listen, I just interviewed your parents. I'd love to get a sense of how you're doing in school. Fine. Okay, well, you know, let me just ask you, like, I know that I saw your grades. Well, my grades are fine. My English teacher is horrible. Okay, well, look. Tell me about your distractibility in class. Do you find that as you're listening to teacher lectures, like sometimes your mind kind of wanders? No, but it's just because the teacher's boring, that's why. Okay, so we don't really put a lot of stock in that. We still do it because a lot of times kids do give us good insight into their symptoms, but many kids are pretty defensive, especially if they're presenting at later ages. Behavioral and class observation. We do behavioral and class observation mainly as a way of getting a sense of what interventions are already in place in a child's environment. What you'll notice on the right is that child and teen self-report, as well as prolonged observation of the child, are listed as common misconceptions. When we go into a classroom to observe a child, there is no way necessarily to know that a child has ADHD just from a brief observation. There's no way. The kid could be performing well in that 30 minutes. It could be an activity they like or that they're interested in. It could be that day when just by miraculous miracle, that's redundant, the child is just focusing. And it's really common for us to go in and we will do an observation and then we'll meet with a teacher afterwards. Teacher will say, you didn't see what we see. You didn't see what's normal. Like, that's not what happens normally in class. They were behaving well for you. And we say, well, wait a second, they never met us before. And they'll say, it doesn't matter. They knew that there was an adult in the classroom, so they behaved. So that's one of the reasons why we don't put a lot of stock in the observation. We'll still do it because it gives us an idea of how a teacher or an adult might be behaving with a child in the environment and where our points of intervention are, which is mainly one of the reasons why we go in, is that most of the adults think we're there for the kid. We're really there to watch you. Teacher feedback. The reason why we get teacher feedback is because, again, ADHD can only be diagnosed if it's present across settings. So we'll tell parents, we need the teachers to fill out questionnaires. We need to know what they're seeing in the school setting. Many parents will tell us, I don't feel comfortable with that. I don't want my kid stigmatized. I don't want you talking to the school. We say that's fine, but we want you to know that in that case, any ADHD diagnosis is tentative. Because what we're doing is we're trying to reconstruct it from maybe report cards and from parent report, but we're not doing our due diligence if we don't talk to someone else other than the parent. Symptom questionnaires I've already talked about. The last thing is psychoeducational and neuropsychological testing isn't necessarily diagnostic. The reality is that psychoeducational and neuropsychological testing gives us supporting evidence. So if we see difficulties with processing speed, difficulties working memory, attentional fluctuations within neuropsychological testing, again, it's not objective. It just gives us more supporting evidence for a diagnosis. Couple things about misconceptions. I've already hit on pretty much the first 4 points. There are no specific medical tests for ADHD. If anyone tells you there is a specific medical test, they're lying to you. I read everything. There's nothing. I get Google alerts. I get every article that can possibly be published in any peer-reviewed journal. When I find a medical test, it'll be in the lobby of my building. Certain testing measures. So some folks will tell you that there are continuous performance tasks that test for ADHD. Like they'll sit your kid in front of a computer and then have your kid, kind of press a button each time something arrives on the screen. My dissertation was on objective tests related to continuous performance tasks. I found that there were significant differences across hundreds of kids between kids with ADHD and kids with no diagnosis. But if you give me any one kid from my sample, I couldn't tell you whether or not they had ADHD with any level of certainty. That's where those tests are. They're supporting evidence. They are not sensitive enough for any one child. Lastly, what we talk about to many parents and educators is that healthy diet, getting enough sleep, and getting exercise improves every single human being's mental health, but it is not a treatment for any mental health disorder. So changing your diet, getting more sleep, or getting exercise does not treat or cure any mental health disorder, but it is a component of good mental health and wellness. So the reality is when we see parents who come in and they say, listen, I eliminate all food dyes from my child's diet, what we tend to do is compassionately talk to the parent about how we're so glad they're taking great steps for their child's treatment. But what we will say in a room like this and not to a patient in front of us is that there's no evidence that that works. And this is the thing. We will tell parents, if there's something that is unstudied, that we believe to be non-harmful, that we don't know whether or not it works, we'll tell parents that. If there's something, on the other hand, that has been studied and has been shown not to work, we will also say that. Dietary changes have been studied and shown not to work. Acupuncture, not studied enough. Don't necessarily know if it works. Mindfulness for ADHD has been studied, and at the same time, there's some emerging research that shows some promise for mindfulness approaches. Most of the research shows that it does not work. So the issue is that we have a file drawer problem with mindfulness. We have a ton of studies that people have done where when you ask researchers, release to us the studies that have non-significant results that you've tried, where you've really thought, this is going to get me something, mindfulness studies appear everywhere. At the same time, there are a few mindfulness studies that are underpowered and do not show enough of an effect size to make them frontline interventions, but that show the possibility that they might work.
But aren't there studies on the dyes that they exacerbate the symptoms of hyperactivity?
No. There's a study that was published in The Lancet, a British journal related to the dyes, that showed it was badly constructed and it's been widely debunked, but it's been incredibly well publicized related to food dyes, and that has been kind of the source. I mean, The Lancet is the source of the vaccine crisis, of food dyes. We've got a lot of issues with The Lancet needing to retract some articles. It's that, look, if I saw any evidence of food dyes, my 2-year-old would not be eating food dyes. It's that there is no evidence that it exacerbates symptoms. In fact, the other thing is that sugar has about the same effect on every human. It doesn't have a differential effect on ADHD. We will see parents who are so concerned about giving a child with ADHD sugar, and we'll say, look, we understand you don't want to give them more energy if they already have hyperactive impulsive symptoms, but it doesn't necessarily need to be that parents are engaging in the kind of hyper concern around that kind of thing.
And omega-3s?
So omega-3s, so this thing, I have a center retreat every year where I make our graduate students do a lit review on anything that we know might be emerging. Omega-3s have some studies that suggest that they might help, but at the same time the effect sizes, and this is a measure of how much that thing really helps compared to other treatments, are still incredibly small compared to what I'm about to go over. So the reality with omega-3s is pharmaceutical companies have already started to package omega-3s as medications, allowing psychiatrists to possibly prescribe them. And there's some emerging research in ADHD and psychosis that omega-3s might be helpful. They are in no way a frontline treatment. Like what we get so mad about is like we're fine with a family deciding I'm going to try omega-3s as an adjunctive treatment beyond, say, behavioral parent training or organizational skills training or psychosocial interventions that we know work. But what breaks our heart is when a parent is saying, well, we're not going to see a therapist for parenting interventions or for school consultation, we're just giving omega-3s, because that's not been shown to work. So that's where we kind of fall on that. And my grad students did a wonderful review of it that I can show a video of at some point. But yeah. What about magnesium in that? Nothing. Just no. Yeah.
Going back to the child teen self-report, what if you have a teen who says, I truly feel like I have ADHD, like I can't focus, something's wrong with me. It's
Great.
really hard.
They're advocating for their mental health.
And it takes 4 months to get an appointment with anybody. And then you go and they're like, are you sure? I think it's anxiety because I have a girl. So like what? Now I'm going to like talks. I'm going to like 3 different therapists trying to get help. I mean, it's crazy town.
I mean, that's just brutal. It's that like when we're talking about that isn't even, you know, issues with.
She's self-advocating. Like she's like, I don't care. I just need to know like what is going on in my head.
And look, where we find people who, you know, are having difficulty getting the right kind of treatment or getting someone to believe their child or figuring out how to get the right clinician that's paired, you know, what we'll say is that you look for resources in the area. Some of them are right here, obviously, right in this building. And then the other thing is that we try to look for any books that we can provide families while they're waiting for this 4-month period. Or, you know, we get lots of emails from families in treatment deserts. So we've treated families from 48 states in the District of Columbia. North Dakota and Nebraska, the only 2 states we haven't treated from. But you know, we get so many emails where parents will say, you know, I'm in this rural area and I have no provider, you know, what can we do? And so we've tried to kind of compile a group of resources. Taking charge of ADHD. It's your daughter or your son.
My daughter.
Read it together. It's Russell Bar. You've read it, okay, good. That's where we start to apply those interventions. Like you're obviously doing the treatment already for yourself, because that book is detailed enough that, you know, many smart parents can start doing some of the interventions with their child.
Also presents itself as ADHD, so I'm having trouble.
Guys, it's on a resource slide at the end of the presentation on your slides. I know, and we can actually sidebar about this a little bit later, absolutely. About the overlap of anxiety and ADHD is always something that requires a little bit more nuance. What were we going to say?
This is just a quick one. Is there any genetic connection or the genetic markers for ADHD?
ADHD is one of the most highly loaded genetic mental illnesses. So psychosis and bipolar are the only 2 that we think are more genetically loaded than ADHD. Tourette's, actually, yes. Tourette's as well.
So you're saying that it could be passed from parent to child?
If someone has ADHD, they likely have a first-degree relative with at least some 2 scoops of the symptoms.
Which is also true of dyslexia, but just wondering,
Absolutely true.
like, is anybody looking at gene therapy, anything like that?
We don't have that technology yet. So like, look, I would love to work on gene therapy as well, but the reality for most mental illnesses is that when you look at the genetic studies, they're related to many, many different genes. So it's not just turning one or another off. It's that gene therapy is going to be a really complex science. It's going to require a multifaceted approach. If it was just, you know, turn off the ADHD gene, I think we'd be looking at breakthroughs much quicker. I think that's what everybody believed when, you know, this field started to emerge, and then it became that pretty much everything is, you know, I mean, you in the medical field, right? What were you going to say?
Hi, I just want to get a clear picture from whole diagnosis. So it will be one interview and the second one's the child interview.
3 hours, 30 minutes of classroom observation, talking to a teacher, filling out some questionnaires that might end up being, you know, 6 or 7 pages, and then some people might decide to get testing done.
The last one.
Right.
The last one's necessary to define.
You can effectively diagnose ADHD from everything above the supporting evidence bullet point, but many people choose to go the supporting evidence route merely because they want the completeness that comes with a 30-page neuropsych report.
In addition to that, most kids with ADHD have other kinds of problems, and that's where you
Right.
can get those data.
Right. So the reality is that if we give this diagnostic interview, one of the issues is that because it takes 3 hours in order to administer an interview to a parent about every single symptom that could occur for their child, neuropsychological testing gets at that without having to interview the parent for 3 hours. You do neuropsychological testing, you're likely to see, you know, those symptoms present during the course of 9 hours of psychoeducational testing, and then be able to have a little bit more diagnostic information based from the child. So it's just kind of different sources that can also be reliable.
To both of them or just one?
These are just 2 names for a very similar thing. Neuropsychological testing, these folks tend to go, so the thing is, psychoeducational testing can be done by more professionals in the field, in that it tends to be IQ testing and achievement testing, some social emotional measures. It can be done in schools, it can be done by school psychologists and a wider variety of professionals. People who do neuropsychological testing get even more training than the people who do psychoeducational testing, and then have more brain-based information related to what's going on. We'll break down things not just from, you know, say IQ and achievement, but we'll break it down into memory functioning and processing speed and all kinds of tests that, you know, get into more basic brain function, executive functions as well. What were you going to say?
Is it common in your experience to have school psychologists say that they can't diagnose ADHD?
Absolutely. School districts are mortified and terrified all over the country of throwing out diagnostic labels. I mean, part of it is that, you look at legislation even in California, where because of legislation happening a couple decades ago related to discrimination and IQ testing, and the fact that there was kind of landmark case legislation around the idea that children of color were performing worse than white children on IQ tests, these things were then disqualified from IEP evaluations within California. Now what's happened is IEP evaluations across many, many different school districts in California now include testing that's somewhat similar to IQ testing, but isn't IQ testing because it's outlawed in California, partly because in the 2 decades since this was outlawed, the IQ tests have now been normed on much more representative samples of children, such that we now know that they're not biased in the same way they were before, but that legislation hasn't been updated. So there are all kinds of things like that. That's just one piece of California educational legislation, and that's all over the country. So what you have are educators who are absolutely scared to use diagnoses, because the other thing is that in IEPs, or in IDEA legislation, the categories that you classify children under for IEPs are in no way related to mental health. They're just categories that have been come up with in educational legislation. So what educators will do is they're fine talking in the IEP categories, like whether or not you are in, say, other health impairment, OHI. Other health impairment often, includes kids with ADHD, but they won't say ADHD. They'll say other health impairment, because that is something they feel they're legally allowed to say. So yes, all kinds of reasons. Right over here.
One thing I think is important to note is that school psychologists don't have the requisite training to give any diagnoses at all. Well, it depends.
It depends on the state, it depends on the locality, it depends on the training. I mean, we see it all over the place.
California, the training is typically not based on any kind of psychological or psychiatric information. It's based on educational performance data.
And we hear this all the time, and yet the issue is that for any mental health professional, sometimes they're the only person. Sometimes they're the only front line for a kid.
For the most part, they're not actually mental health professionals. School psychologists tend to be educators.
I'm with you about where the law is. I'm telling you about where it happens in practice. But that's kind of where it is. Yeah. So here's the thing. In terms of evidence-based interventions for ADHD, this is where we get into what works. So I'm going to start moving into what those strategies look like in just a second. This is a table taken from the most recent review article in the Journal of Child and Adolescent Psychology by Evans, Owens, and Bunford in 2014, looking at what are the most evidence-based interventions for ADHD. Now, this is an article on psychosocial treatment only. So the most evidence-based intervention for ADHD, based on longitudinal studies that follow kids for decades, based on research on treatment effectiveness across a whole host of settings. The best treatment for ADHD is combined medication and psychosocial intervention. Now, that is, to kind of make sure that we're being clear about that, it is slightly more significant than either intervention alone. So in that sense, it's not as if medication and psychosocial treatment are so much more powerful than either treatment alone. They are just significantly more powerful, but not so much more powerful that either treatment alone doesn't work. So the reality is that medication can work on its own, and psychosocial treatments can work on their own. But psychosocial treatments for ADHD and behavior disorders take a number of forms. Behavioral parent training, behavioral classroom management, behavioral peer intervention, combined behavior management interventions, and organizational training. Now that's the thing, that's the level 1 well-established category. Every intervention in that category involves training the adults in a child's environment on the skills that you're trying to facilitate in that child, and then making sure that they have a consistent way of eliciting those skills, reinforcing them, and ensuring that the child is kind of generalizing those across certain environments. You will notice what is not on this list: individual psychotherapy. Now, for a kid under age 12, individual psychotherapy is tantamount to malpractice. It is not effective. Now, if their diagnosis is more complex in the sense that they have anxiety or PTSD or depression, individual psychotherapy can be very effective. But bringing a kid with ADHD into the office and telling them to meet with a therapist to discuss their problems with focus, and then leaving the office to go and apply the solutions related to focus that they discussed with a therapist does not work. We have decades of research to support it. And it's not because the child doesn't buy in enough, it's not because they don't want to try hard enough, it's not because they don't want to work, it's because it doesn't work. So what we tell parents is if your child has anxiety, depression, or PTSD, absolutely, bring them into an office. Individual therapy can be effective. But if your child has ADHD, start with the adults in their environment. Now for kids over age, say, 10 to 12, individual therapy starts to become something that we can work in. It is still the least effective arm of intervention. So when we do cognitive behavioral therapy with teenagers around their ADHD, there is still mixed evidence that is effective at all when it's alone. However, it can be a nice addendum to behavioral parent training approaches, to behavioral school consultation, and to intensive approaches around the adults in a child's environment. But make no mistake, if you know a child with ADHD, the most significant agent of change is the adults in their life, not necessarily the child's acknowledgement of their difficulties or willingness to work on them. I'm going to talk about how we end up working on that in a second. The thing that we have kind of at the right of the distribution, so one other question that didn't come up earlier about treatments is that neurofeedback is something where we have a few studies that show that neurofeedback could be effective for ADHD symptoms. The issue is the neurofeedback programs that have been studied are not commercially available. The stuff that's commercially available is normally bunk. And the stuff that we do in neurofeedback doesn't tend to generalize to real-life tasks. It tends to generalize just to tasks that are very similar to whatever you've just done in neurofeedback. And that generalization effect also doesn't last. So when we do behavioral parent training, when we train parents on certain behavioral strategies to approach with their child, those strategies show that 3 years on, parents are still seeing effects of that treatment. Whereas with, say, for example, neurofeedback, even 6 months on, the treatment effects have dissipated. So we look for treatments that also have that longitudinal holding effect, where even if you're not actively engaged in treatment after the initial period where you're actively applying an intervention, you can still see the effects of that treatment. So I'm going to jump in now to intervention. These two slides are quick. The thing is, the questions that we get about ADHD prior to intervention are the things that make parents and educators pull their hair out. It's, how is it that I ask them to do one homework assignment, it's a 4-hour battle, but then the second they get the iPad, they're docile the rest of the evening? And the reality of this is that, as I said before, variability is what is the rule in ADHD, not necessarily the exception. So what you're expected to deal with is noise. So for example, I got a question earlier about, do I need to have someone sitting next to my child at all times to ensure that they do what they need to do? One of the issues with ADHD intervention is that part of it is teaching parents and educators strategies. The other is managing expectations. And that's a huge aspect of treatment. It is that there is no cure for ADHD. There is no way to make it go away all the time. You will be tolerating these symptoms presentation in various situations for the entire course of the child's development. We cannot get them to go away. Even medication. Medication is supposed to wear off in the evening to allow the child to sleep. It's something where we know that in the evening, even for a child on ADHD medication, parents are still going to need strategies to manage that period from 5 o'clock until bedtime in order to make sure the child is doing what they need to do. So at some level, what we're trying to do with the beginning stages of treatment for ADHD is to help parents to think to themselves, is this task something they're not interested in? Is it dull? Is it boring? Is it repetitive? Have they done it thousands of times in their lives? In that case, manage my expectations related to what I'm going to get, at least at the outset of my efforts to intervene on this particular task. You can get better functioning, to be sure, over time. It's just that you won't always get perfect functioning. And even like with stuff like morning routines, which are frequent flyers, kids with ADHD, many of them never acquire a morning routine, ever, that they do reliably or that they get done in a certain time period. That's okay. Like, what we work on is figuring out how to make sure that they get what they need to get done in their morning routine, at least in a timely fashion during the years they're living at home, and that it makes it so that the family conflict is not so terrible that it impairs everyone's functioning and cortisol for the rest of the day. So here are some important factors in ADHD intervention. So the first thing, and this is drawn, by the way, every single slide I'm about to present, even if I don't get through all the material, is drawn from books that are included in the resource slide that I have at the end of this presentation. So this slide, for example, is drawn from Linda Fiffner's book for educators called All About ADHD. It's just, I break it down more simply for you and in more sound bites. She breaks it down in longer chapters that are fantastic summations of the research. All About ADHD actually is a short book, though, with lots of pictures. So, important factors in ADHD intervention. Structure. Now, this doesn't mean broken record structure. So many people interpret this as I should just restate rules over and over and over to the child and routines and expectations. That's actually a negative behavioral strategy. It doesn't work for any human. That's another thing I'll emphasize. Everything that I'm about to talk about works for any human. If you are using a behavioral strategy that would piss off your partner, a friend, or your boss, or an employee, it's probably not an evidence-based effective behavioral strategy. So we're going to get into some examples of that. But these are some of the most important factors. First, we want kids to know what the rules, routines, directions, and expectations are for any situation. Now, that does not mean that you post rules about every situation they could possibly encounter around your house. We like parents to think of this in terms of small bites. So if you've got a situation that you're trying to work on with your child, what we try to get parents to do is figure out what are the major 4 expectations for this situation. We give you a max of 3 or 4. What would I like them to work on? No human being can change a ton of behaviors all at once. Most of us can't even change one behavior that quickly. For example, one of the things that I'll say to a group like this, how many of you have come up with an exercise plan in the last month? Anybody? Yeah. How many of you have adhered to your exercise goal perfectly from the moment you set it? Right, nobody. And the reality on the exercise goal piece is that, especially when we set goals for any human being, we want them to be clearly deliverable, we want them to be incrementalized, we want them to start with some small bar and then raise the bar as we go forward. So for example, I make every single support staff member who joins our center come up with one behavioral goal for themselves in their first few months they work for us. One of the most recent goals that one of our staff came in with, she came in and she said, I'm going to exercise 3 times a week. And our staff said, fantastic, no judgment. How many times did you exercise last week? She said, none. And they said, great. How many times did you exercise in the last month? And she said, none. I've been paying a gym membership for 4 months. I haven't gone. And we said, okay, so 3 times a week is a lot, especially in the midst of starting a new job and a ton of other routines. And she said, no, but I need to do it for myself. I mean, this is what I need for my own mental health. And we said, we're with you. We want you to exercise 3 times a week. You start with 1. That's it, 1 time. When are you going to do it? Exactly when is it going to happen? How are you going to pack your bag for that morning? We've got to really prepare for that goal. So what we try to do is operationalize just a few routines and then work on those kind of intensively. Salience. If you are trying to present something to a child with ADHD just by way of mouth, it's likely to fail. I'm just going to throw that out there. It's likely to fail. Because what you are relying upon is A, already the most unreliable form of human memory, which is verbal working memory, or oral working memory. And then the other thing is that kids with ADHD tend to have deficits in that area, for those of you who've seen neuropsychological testing. So if you say to your kid, listen, I want you to pack up your backpack for tomorrow, I want you to go remind your brother that we've got this thing in the morning, and I want you to make sure that you go back in your room and put that thing on your desk in your backpack as well. What are you likely to get?
Nothing.
Right, there you go. 1, maybe 2, if they really cared about the other thing that was on their desk or something like that. And the thing is, that's true of a lot of humans. That's true of likely directions you give to your partners. So like, you might give your partner 3 directions, being like, get avocados, get some corn, also I need a steak, that we're gonna cook tomorrow night, and they come home with beer, corn, and like, something resembling the green color of an avocado, but they couldn't remember what the green thing was. But like, that's true of most humans. So what we try to do for kids with ADHD is remember what works for everyone, which is visual cues, creative reminders, prompting, and repetition. So one of the things that I say to a lot of the teenagers that I treat with ADHD is I say, look, if you've got a goal you're working on during the week, I want phone reminders of it. I want sticky notes on your mirror. I want there to be something in your computer that you're opening up and you're seeing that pop up. I want to create your desktop background is going to be your goals for the week. I want it to be wallpapered in their life, if I possibly can. Now the other thing is we get scenery blind very quickly. So the reason why we talk about creative reminders is that one of the ways that I demonstrate this to kids with ADHD in my office is that they've likely been in my office 10, 15 times. And I'll say, great, tell me what one of the 3 paintings behind you is. They've been in my office many times. No one ever answers. They don't know what the 3 paintings are. They don't know it's a beach scene, it's El Greco painting, and it's the Manhattan skyline. They cannot remember what those things are. We all are scenery blind. If I ask many of you what's written on that board that you likely read when you came in, you might read it the first time, but then if we leave what's written on that board, 10 times you're in here, you may never even remember anything's written on the board at some point. We all have difficulties with perception that make us scenery blind. So if we're going to remind anybody of clear rules and expectations, and that Post-it note's been there for longer than a few days, we probably have stopped paying attention to it. It's no longer novel. So we're always trying to switch it up. How do we make the reminders a little bit more interesting? How do we make the text messages more interesting? How do we make the Post-it notes a different color? I have one dad who really loves drawing his son pictures on each of his Post-it note reminders. So what they do is that each day there's something novel when he opens his laptop and is reminded of what he's got to prioritize for homework. Consistency. So we're going to talk about this related to behavioral principles in just a moment. But, yeah, those behavioral principles. But what we're looking at with consistency is most people interpret the point on consistency as like consistency in punishment. It is consistency in reinforcement and consistency in punishment. It's a kid knowing the guardrails and then also being better than your instincts. We're going to talk about those instincts in a second, related to consistency. So when we also give corrective feedback, it's that we're consistent in the way we give it so that it's actually effective. I'll also talk about that in the next slide. Motivation. Kids with ADHD have been shown in the research to be less sensitive to punishment, more sensitive to reinforcement, and more sensitive to anything that they find motivating, especially if that thing is salient or they've got a number of things to choose from. Humans don't like doing this. They don't like having to think like this. What most humans do, and this is what I mean about instinct, is that we are negative behavior detectors. So the example that I give is very few of you have likely thought during this presentation, my God, 85% of this audience is so attentive. I mean, they are taking notes. They are doing such a great job tracking the speaker with their eyes. I think that most of the questions are really pertinent to the topic that's being talked about tonight. We just don't think like that. What we think is, I remember that one annoying thing that someone did during this presentation, and that got to me. Or we'll notice that more often. That's what our attention is kind of drawn to. Well, from an evolutionary perspective, we are negative behavior detectors. Sometimes I show a slide in presentations like these of a bunch of kids in the playground. And the kids in the playground, there's 20 kids, and there's one kid clearly bullying another kid picking his nose, another kid who skinned his knee. And then the rest of the kids just kind of playing nicely. And you ask a group of parents, what do you see before I say this point? First three hands that shoot up. That kid is aggressing that other kid. That kid has a skinned knee. That kid needs help. That kid's picking his nose. We notice what's socially unacceptable. We notice when people are hurt. We notice when people are doing things that might cause others' safety to be compromised. That's a good instinct at some level. It's not good for behavior management. We tend to notice in our partners what's most annoying. We tend to most often use verbalizations to let them know that. We do not, on the other hand, tend to notice when our partners are doing things that cause our love and joy with them to increase and explicitly label that verbally. We just don't. That's not in our instinct. Even for those of you who are thinking to yourselves, I am good at that, I can assure you, every one of us can improve. So the reality is that when we look at motivation, what we get back whenever we present this particular point on the slide is we get back, wait a second, you're saying to bribe my kid? Everyone's bribed. Are you saying that we need to have concrete reinforcers? Everyone gets concrete reinforcers. I am concretely reinforced to be here. I am paid to do this work. Now, the great thing is, I am happy doing this. I would do these sessions, continue to do them even if I won the lottery. However, I do them for fewer hours. I would not be here past dinner time. And I would also never write a piece of paperwork again. I have to be concretely reinforced. Literally, I think every time I write a progress note, this is what they pay me for. Because otherwise I do everything else without pay. But it is not a problem that we're concretely reinforced. There are elements across the country in educational settings and in the media talking about this false dichotomy between internal motivation and external reinforcement. It's BS. I'll try not to swear again in the recording. It's based on a body of research that was deliberately flawed in the mid-90s, and it has no basis in science. It's been widely debunked by anyone of respectable scientific credibility. But the reality related to this is this. We are all internally motivated to do certain things. I am internally motivated to seek a sushi restaurant because it is pleasurable to me after this talk is over. I have already researched 3 sushi restaurants in this area between me and my hotel. At the same time, I am not internally motivated to write the notes from some of the FaceTime sessions that I just was telling you guys about that I was doing with college students before I came here. I know that the only way that I'm going to write those notes tonight is if I hold off on sushi or turning on any replays of Thursday Night Football before I write those notes. That's how I need to set up a structure externally reinforce myself. That is okay. That's what we all need. We need to figure out where our bars are, where we need external reinforcers to get us over a bar, and where we're internally motivated. This is also why we do inventories related to motivation with kids with ADHD. We figure out what are they motivated toward, what are they not motivated toward. Then we use what's called the Premack principle, which is we use what they're motivated toward to get them to do the things they're not motivated toward. That's it. That's the science right there. The last thing I'll throw out there is stimulation. Look, we can't make everything stimulating, but one of the reasons why they want to be on iPads so often is that iPads are stimulating for a number of reasons. They've got all kinds of choices, they got all kinds of things to do, even if they're not playing games on the iPad, even if it's just looking up articles on Wikipedia or checking out a panda on the World Wildlife Foundation's website. It's that when we can figure out ways to make things creative, to pace them in kind of unpredictable ways, or to make ourselves flexible in the ways we capture someone's interest, the more likely we are to capture a kid with ADHD. Now, this is the most important slide that I will present tonight. And I realize it's in the last 25 minutes or so that I'm going to be with you all, so I'm asking a lot of your attention in this moment to pay attention most to this slide. Because after this slide, I'm going to apply it to the various behaviors that we've talked about here. This slide is the most important way of kind of conceptualizing the paradigm of behavioral shaping for all human beings. It is that if we want to change a behavior, what we often start with is the behavior we want someone to stop doing. This happens in couples therapy, it happens with bosses and employees, it happens with parents and children. The difference is in couples therapy, you can leave your partner. With bosses and employees, you can look for a new job. Children don't get to look for somebody new. So we end up, that was an interesting emotional reaction. I'm sorry for the fact that children can't. But at the same time, what I think that emotional reaction was related to is the idea that we oftentimes believe that children then just have to take it, which is kind of an issue for the way that we shape their behavior. Now, in terms of the way we shape behavior, we often start with something we want someone to stop doing. So I'll use an amusing anecdote from a couple that I'm working with right now. They talked a lot about the kind of workload at home, which is a common couples issue. Who does the laundry, who does the dishes, that kind of thing. The thing is, between the two dads, one of them does a lot of the laundry and a lot of the dishes and is very mad that the other dad does not do a lot of the laundry and the dishes, which is a common issue for couples again. So we talk about it as we say, like, what was the way that you've intervened on this issue so far? Now, his partner was very quick to inform us of how he has intervened on this issue so far. Long sighs, rolling of the eyes, insults, pointing and just gesturing at things and doing this kind of stuff, and then commonly used statements like, I can't believe we have to have this conversation for the 25,000th time. Please put your dang laundry in the dang hamper, though using other more colorful terms. This is the issue. No human reacts well to that for behavioral shaping. We all do it. So in that sense, I don't want to increase shame or guilt in this room. This is how we all communicate. For 75% of the human population, what ends up happening is we want to avoid that kind of conflict in the future, or we care about the person who's saying this and we want their approval, and we may do some kind of follow through on what they might be asking us to do. Not right then, but later on. Because we have the phenomenon of reactance, which is how whenever any of us are dictated to in a negative way or criticized, we tend to fantasize about setting fire to the thing before we actually think about fixing it. So, the reality here is that when we yell at people, when we criticize them, when we ask them questions over and over, or we give them commands over and over, these things do not work. We teach parents to stop asking questions about behavior over and over, stop criticizing over and over, and stop giving repeated commands with diminishing returns. So what this sounds like, just to operationalize it, because we code every verbalization out of parents' mouths, is it sounds like, what did I just say? What did I just, look at me, look at me, look at me, look at me. What did I just say? What was the last thing I said? Get that thing off your desk and put it in your backpack. Thing off the desk, thing off the desk. Get the thing off your desk. God damn it, why don't you hear me? Now, every single verbalization I just made is in the first three categories I just said. It's either questions about behavior. Questions are fine. Questions about behavior don't necessarily tend to work too well with any human. They're repeated commands, and then at the same time, they're criticisms. Saying don't, not, quit, stop, no. Our issue with that kind of speech is that it does not shape anyone in the right direction. So what we try to help people do is start thinking about what speech does shape people in the right direction. It is presenting neutral information about why a task is important. For kids, that means 1 to 2 sentences of introduction. 1 to 2 sentences. Honestly, if you can get it down to just one dependent clause, we're good. But it's that you don't need to over-explain. For most kids, the troubling situations that you are confronting with them, they have already confronted thousands of times. If they were going to listen to the amazing, magical way you phrased it, those first few thousands of times, they would have listened. Let's stop banging our heads against a wall around that. So you give a little bit of a briefer introduction, framing the situation, and then what you're trying to do is you're trying to catch anything they do well and praise that particular thing, or you're trying to describe anything that they do that is in line with what you would like to see, or you're trying to reflect whatever verbalizations they make that you deem appropriate. Now what reflection is paraphrasing what someone says without asking a question. It's a technique we use in couples therapy. It's a technique we use with kids. It's that they say something like, you know, at school today I played with my friend Byron. Okay, so you were playing with Byron at school. That's it. You just pause. Most people, when you reflect without asking a question, they just say yeah and they continue on. Many of you did not realize, because most people don't realize when someone's doing this in a genuine way that they've practiced, that each time you asked a question at the beginning of this presentation, I would first paraphrase some of the things that you said and then move on to thinking about an answer. It helps people to feel heard. It helps them to feel like you care about what they have to say. And it also tells them you're allowing them to have the lead in the conversation. With kids with ADHD and behavioral issues, they almost never have the lead in the conversation. They're almost always being told, here's where you need to be within these guardrails. So in the moments that you can give them the lead or reflect what they have to say, that active listening skill is what we call money in the bank. It makes it so that they're more likely to listen later on. Now, the way they operationalize this based on the hierarchy is this. What we ask parents to do with a kid who has ADHD is plan ahead for the behavior they would like to see. Then we ask them to do a modeling exercise. We say, if you'd like to see this behavior, how often do you engage in it that you can self-narrate for the child? This is where we often get sly smiles. So like a parent will say, I want him to sit down and do his homework and stay calm in doing it. We say, great. How often does your child see you stay calm in frustrating situations with them, their siblings, or in anything in life? And the parent will say, well, look, I'm an adult. I'll say, right. Understood. And again, not trying to increase guilt or shame, but if we want to see the parallel process that makes them see the value in this behavior, we have to model it ourselves. So you're going to be working on the same thing in the same way that you're asking them to work on it. Now, the next thing down is we teach the child what the behavior expectations are, not too many at once, only a few we focus on. When we do interventions with kids with ADHD in the clinic, it's that we do interventions where we have 2 or 3 behaviors that we're working on at any one time. That is an evidence-based number right there. More than 2 or 3 behaviors tends to lead to great confusion within the system. It leads to a kid trying to get credit for certain behaviors and not others. They start picking out which tasks they want to gamble on, all kinds of stuff. You focus on 2 or 3. Once you get those 2 or 3 down, you move on to others. That's just it. We ask parents to give us kind of the ones that are their most concerning first. What we teach people to do is to frequently reinforce positive behavior. So you do it verbally, you do it through helping the kid to earn an incrementalized progress towards certain privileges or certain rewards. This is the most powerful intervention in ADHD. It is that you say what you're going to do is you're going to go against your own instincts, you're going to catch a kid being good, and kind of try to make sure that you praise them as often as you can for even small steps toward the behaviors you'd like to see. And then secondarily, you take that motivation inventory you just did of all the rewards that they care about, all the privileges they care about, and you link those things in some incremental fashion to their performance of certain behaviors. So for example, a kid that I consult with in this area, or consult about in this area, is a big fan of Fortnite. Fortnite's a big game, and for many of you who have any boy of any age right now, you're likely aware of what this is, and many girls. We talk about Fortnite. You know, the reality is with screens, we help parents to come up with doses of screens that they feel are appropriate for their child. So this particular family said, look, we feel like if he meets his behavioral goals, we're willing to give him 30 minutes of Fortnite each day. 30. So we said, okay, sounds good. He's got 3 behavioral goals. Each of those behavioral goals is linked to 10 minutes of Fortnite each day. Now that is a very simple behavioral process. And we work with parents to make sure we have a really clear rating system for how you get those 10 minutes, because parents are really good at spoiling. Meaning that the kid has done the exact behavior for 30 minutes of the 40-minute period of assessment, but the last 10 minutes are hell, so we take away the Fortnite. And that's where we don't get good behavioral shaping. We actually have to give the reward for the child performing the behavior the majority of the assessment period, rather than take it away for the fact they spoiled it in the last 5 minutes. That's not how good behavioral shaping works. Now, some systems work on token economies, where what we do is we give a kid points, checks, or dollars that they can then use for later rewards. That is the same as paying someone a salary. It's not bribing your kid. It's not making it so that they're dependent on concrete reinforcers for the entirety of their development. It is merely using the best of behavioral science to get the behaviors that you want that they may not be internally motivated to work on. But this is the bullet point that we beef up the most in behavioral intervention, is that we get people to start doing more and more of that. The next one that we work on is the behavioral process of extinction. So reinforcement is increasing the chance that a behavior you like will recur. It's actually increasing the chance that any behavior will recur from a behavioral perspective. It's just that what we try to get parents to do is make sure that reinforcement is only applied to behaviors they like. To give an example of what that means, I had a kid once that I was consulting on in a school in Canada, and they said, look, this kid doesn't finish his math homework in class. And I said, okay, what happens? They said, we punish him. I said, okay, well, when you punish him when he doesn't finish his math homework, what do? They said, we send him to the school counselor's office for counseling. I said, okay, show me the school counselor's office. School counselor was named Cheryl. I meet Cheryl. Cheryl has a voice that sounds like a melody over a frozen stream in one of those ocean sound videos. Cheryl shows me her office. It has a waterfall along one side and mindfulness books on another part, board games on another, and this rug with beanbag chairs that you can sit on and kind of dim mood lighting that's made from a purple tissue paper that's put over a light at the top. And I said, so when he doesn't finish his math, he gets punished by coming here? And she said, yeah. And I said, well, what do you do for his punishment? She said, well, we usually do about a 3-minute centering exercise, and then we play a game to help keep his emotions back to baseline before I return him back to class. And I said, does he usually win the game? And she goes, oh yeah, he always wins the game. And I said, so this kid is punished for not doing his math homework by a mindfulness exercise followed by a game with an attachment figure he likes that he usually wins. I said, I'm just going to switch this up because reinforcement is increasing the chance of behavior presenting. Punishment is decreasing the chance of behavior presenting. This isn't punishment, this is reinforcement. So what we said was, when he finishes his math, he gets to go to Cheryl's office to have a spa time. Oddly enough, I consulted with that school again 2 weeks later, and we found that that child was doing amazingly better at finishing his math in order for him to earn his spa time with Cheryl. We also decreased the frequency of it in that it was every 3 days he gets spa time, and only if he finishes his math on 2 out of the 3 days. So we kind of up the bar in that way. So the next thing down is extinction. Extinction is a behavioral process in which you starve out a behavior that is dependent on something for its survival. So ignoring is an example of extinction. It is that what we hypothesize that a child's behavior is dependent on our attention to survive. And if we don't give it attention, then it might die. Now, this is the hardest behavioral principle to apply for any human being. The reason is, if you try to ignore something, you have to ignore it through what is called the extinction burst, which in behavioral analysis is that the behavior gets worse before it gets better. So in other words, a parent will decide that the behaviors that are often most dependent on parent attention are whining, berating you, swearing, telling you that you're wrong, trying to lawyer you around what's for dinner and that kind of stuff. It tends to be conversational. What we tend to find is that what parents will do is they'll say, I went home and I tried to ignore this. He was just going at me about the fact that we were having chicken that night and he wanted burgers or chicken nuggets or something like that. And I ignored it. I ignored it well for the first 5 minutes, but he kept at it. He just kept talking about it. Finally, I was like, no, I'm not giving you any damn chicken nuggets. You eat what's put in front of you and go to bed hungry. Now, what we will then say is, then what happened? And the parent will say, then I gave up. I walked out of the room. I went to my bedroom. I watched Real Housewives or The Bachelor or whatever it was. It's a real example from a parent, which I love The Bachelor. She knew this. So we almost went off on a side note about that. But then kind of came back and I said, well, what happened? And she said, well, the kid made chicken nuggets for himself in the microwave. So the issue was this. The ignoring didn't continue through the extinction burst. The adult didn't stay in the situation to manage it. And what the child learned was 2 things. One is ignoring gets a reaction that causes the adult to be expelled from the room, negative reinforcement. And once the adult's expelled from the room, I am the king, and I will now have chicken nuggets. So our problem was that a parent will come in and they'll tell us ignoring didn't work, and we'll say, here's the thing, I love your effort. And this is our praise. I love your effort. You really tried to ignore that thing about the chicken nuggets. We want to give you some more strategies to help you see that ignoring through, because in the end, there were other things that we might want to tweak in this situation to make it so your child doesn't have access to chicken nuggets. But the thing that we look at with ignoring as well, and this is another point, we ignore the behavior, not the child. So a lot of people think that ignoring involves freezing out a kid. It does not have to be that. There was a kid right before I left for California who was jumping on my couch in my office while excitedly telling me about how he'd done well on his goals for the week related to social skills. Now, I don't like him jumping on my couch. It was just shampooed for the first time in 4 years. It's very clean, and he was also tracking in some mud from the recent rains in New York. So I was not happy about the jumping. Now, my instinct before being a behaviorist would be to say, hey, do you jump on the couch at home? Huh? You want to sit on my couch? This is disrespect to Dr. Anderson right here. Sit down on my damn couch. That's what I really want to say to him. Instead, what I said was, I love hearing about what you did with your friends. I tell you what, do you want to take a walk around CMI while you talk to me about this, or would you rather we sit in our chairs? And the kid goes, I think we should take a walk. I said, great, let's take a walk. I have actively ignored that behavior and made it so that he chose a behavior that I liked better, And each of those choices I was willing to do. One of the issues with giving choices for adults as a way of ignoring is that frequently we think of the choice that we want, and then we have another choice that is a throwaway that we don't really want, but the kid chooses it. It's rough. I was consulting in a school with a PE teacher very recently, and a kid has a stipulation in his IEP that he can have a snack, partly because the kid gets hangry, and that really exacerbates, how willing he is to engage in his schoolwork. So,
Did you say
hangry, yes. Sorry, one of those slang terms that I get from the East Coast. But no, so the thing was, the PE teacher was sitting there and was wanting to give the child a hunger break, and said, so the PE teacher come to pick up the class in the classroom and said, do you want to stay behind and eat your snack here, or do you want to eat it when we get to PE? And the kid said, stay behind. And the teacher then had to go through this whole rigmarole of finding someone to cover the classroom so the kid could eat the granola bar that he had alone in the classroom while the rest of the class went to PE and started PE. And I went back to that PE teacher later and I said, those two choices were great. Did you care about both of them equally? And he said, no, I wanted him to eat the dang granola bar when we got to the PE class. I said, then in that case, it's, do you want to eat the granola bar with me when we get to PE class, or would you like to eat it with, my assistant or something like that? Give him a choice of the person once he arrives, rather than the setting which you didn't want to give him a choice of. That's always hard to do from a proactive point of view. But ignoring takes many forms in terms of how we can ignore a behavior while still providing some level of redirection to a kid. We're just not criticizing them about the behavior, and we're not giving them commands around the behavior, and we're not telling them that what they're doing is wrong. The next level down is giving clear directions, reinforcing.
You were going to talk about the extinction burst.
Yes, I was talking about that.
When a kid is whining and you're starting to get mad, then you've got to wait it out. Is that what you're saying?
Yes. So look, here's the thing. It's not that you just wait it out. There are a host of other strategies within this, in the sense that what we tell parents with whining is you can be waiting for them to engage in anything else, even while they're whining, that you like. So the ignoring exercise we do in Kasdan's model of behavioral parent training is we give parents an exercise where this is around session 5, where it's a narrative. It's a manualized treatment. You can buy the manual if you want to. I see people writing it down. It's parent management training. You can buy this and see the exercise for yourself. But it's an ignoring exercise where basically what we're leading a parent through is it's a 12-year-old girl, and she is working on her homework. And what's happening is, in the narrative, you see that it says she pulls the book toward her and begins writing notes out to the side for annotated reading. But at the same time, she says, it's all your fault I'm starting this work at this time of night. And this is why I'm going to finish too late and I won't have time to watch my show. But she continues working and annotating her notes. Then about 10 minutes later, she says, you know what, I hate this, pushes the book away and says, I'm taking a break. And then walks away, takes a break for a few minutes, comes back, sits down, starts work again. And it goes through a couple more situations, but we ask parents, what would you reinforce in that situation, and what would you pay attention to? And most parents at the outset of treatment will say, well, this what she's saying is unacceptable. We can't allow her to say this. We say, we agree with you at a certain level towards the end of treatment, but the reality is your kid is saying this all the time right now, and we want to help you to get it to go away. So as much as we all agree that she can't be saying this, there are certain behavioral strategies that are effective. By the time people get in the middle of treatment, they say, I will pay attention to all the time she's working, and I will ignore everything she says. And that is the key. It is that she says, it's all your fault that you're doing this. I love the fact that you've started to annotate the text already. I'm here to help if you need it, but I'm going to watch for you to do the next few pages, because I know you just have to get to page 53. We teach parents to ignore what's being said and to engage in what's called persistence coaching, which is praise the last good thing the kid did, prompt the next small step in the process, wait and don't say anything else. That's it. So the kid says, it's all your fault I'm doing this. Well, you know what? I love how you're working on those math problems just recently. And, I think that you're going to be able to finish the math worksheet within probably the next 10 minutes. Wait. It's really rough, but we're not asking you to just sit there and take it. It's more that taking on active strategies. Telling me 5 more minutes. Great. Thank you for the warning. So the thing is, this comprises, many different things. And in the books that we have at the back, so many of you were writing down parent management training. The books that are in the resource slide at the back, Kasdan did parent management training. Kasdan now is in semi-retirement at Yale. And then what he did was he was trying to write a book for parents. So he wrote the Kasdan method for parenting the defiant child. It's not on the list. Now the problem was that book did not fly off the shelves, mainly because no one wanted to be seen in the bookstore with it. So he shortened it by 100 pages and titled it The Everyday Parenting Toolkit. That one flies off the shelves and is one of the best sellers on Amazon. So that book is in your list at the back. So if you want to know more about active ignoring strategies, there is an entire chapter related to just that in the Everyday Parenting Toolkit. Yes?
What's missing from your list that I really need is a book for children to counter the I think I'm stupid.
Yeah.
This is what, do you have any recommendations for kids to read?
It's missing from our list too. One of the things that we find is that we actually have a project right now where I have 2 undergrad interns working on building us a library of kid-friendly books about mental health disorders. There are lots of great ones for teens. The ones for kids, like sometimes they're just scientifically irresponsible, sometimes they're just wrong. Like, and even though they may be dedicated to destigmatizing, like one of the books that we have that's really destigmatizing, it's great, talking about a child's brain, it's super wrong about what ADHD is. Like, it talks about the kid being scared to speak in class because she's so nervous that people will see her ADHD, and it's like, that in no way kind of like orients to most kids' experience with ADHD or speaking in class. And then it starts talking about how like she hasn't spoken in class in 4 months, like she has selective mutism. She doesn't have ADHD, but it's talking about how she's dealing with it. So our issue for kids and kind of young readers is that what we'll tend to look at actually is supportive like YouTube videos around this kind of thing, where we'll try to have the kid watch a video around like kind of what ADHD is, and we tend to be like brief and from credible sources, and then just talking to them about how ADHD, the kind of talking point that we always give is that ADHD is part of your landscape. It's that like, this is one thing. And I'll tell kids just the same way that like, I wasn't necessarily that athletically talented as a child. You know, we know that you're gonna have difficulty with focus or distraction over the course of your development. That just means it's something that you end up having to practice more than other kids, but here are all the other strengths that you have. And we try to situate it in kind of like, you know, having them do diagrams of themselves and their talents and the things they're interested in. Because really what we want them to understand is that ADHD is just one aspect of what makes them up. But at the same time, the issue with ADHD is that it is one of the more noticeable things to adults in their environment. And that the fact that I wasn't good at catching things was something that was only present at recess with Chris Leslie and Brian Bastio. But if any of you know those kids, they bullied. But you know, that's kind of where we are. I'm going to say one more point on this before I go to the questions. Sparingly providing immediate consequences for misbehavior. There is a lot on this in the books that are in the resource slides. It is one of the hardest things to do well as a parent, is to provide consequences in increments, not to take away everything all at once, to make sure it's linked to certain behaviors that you'd like to give consequences for, to sparingly use it, and to deliver it calmly, and then not make it so the kid's in purgatory once they've gotten a consequence. What was your question?
I just have a question about how, I suppose, how open you recommend being with the child about this. Like, you know, I feel like if I tell my 7-year-old, you know, how he's got ADHD,
yeah,
might be inclined to say, well, anytime you ask him to do something, I can't possibly do that. I've got this ADHD here.
So you're right that there may be the unintended effect for many kids of making it into a crutch where they say, oh, well, that's my ADHD, which definitely happens. But our line, and this is drawn from research-based approaches, is tell them what's developmentally appropriate, tell them early, make sure they know. Like, it's not, we do not advocate keeping the information from a child. However, especially with young kids, we may not use the label ADHD with young kids. We may just say, you know, this is something that we're practicing. Like, we know that when you're on rug time, you know, with your friends, it might be a little bit difficult for you to control your body, or it might be a little bit difficult for you to be able to pay attention to what the teacher's saying. We're gonna help you with some strategies, and your teacher's gonna support you as well for working on that. But we figure out how to be open with a child in a developmentally appropriate way. With teenagers, we'll say ADHD, absolutely. But we work on those scripts with parents.
Yeah, I mean, with younger kids, I really think what you're just talking about is focusing on the symptoms that you're hoping to change,
right,
or behaviors, is much more, makes a lot more sense to them, and also sidesteps that issue of, wow, I don't have to do it because I've got this thing.
Yeah, we go quick answers in one sentence. Yes.
Just, I think a lot of the stuff that you were talking about really geared towards maybe a younger kids. No.
I promise, it's not. We do the same things with teenagers. It's just that the reinforcers end up looking different. Reinforcers are curfew, their access to social life, their access to screens, their access to their phone, those kinds of things, but it's the same approaches. Defiant teens is the approach we use with teens.
You just didn't talk in that language though where I could apply it. I guess I need things really spelled out because my teen it's so different. You know?
Right.
They have attitude and they have, like, they're smart and they know it all.
I hear in the feedback, I want to take another hour to talk about teens. Unfortunately, we don't have that time. But look, same thing. And, the books that I'm promoting, by the way, I'm in no way involved with and get no monetary kickback. But the Kasdan book, the Everyday Parenting Toolkit includes chapters related to how to apply these approaches to teenagers. I'm going to hit 2 sentences here and then here and here.
I have a question about this. I've been hearing buzz about this Achilles Interactive Lab trying to get
approval on a video game treatment for ADHD. I don't know if you've heard of it. And I don't know if they've gotten approval or not.
As soon as I see a peer-reviewed study, I'm ready. That's what I got. Yeah.
So I'm trying to get like a picture of, there's a lot of intervention that you mentioned that I can totally visualize using for hyperactivity.
Yeah.
But like inattentiveness, it's such a hard thing for teachers to even notice that a kid has that, or like how do you reinforce them paying attention? Like
Time periods. Focus for time periods. We do it in sprints. So it's that we want you to focus on this worksheet for this amount of time, and that is what they are assessing. And we start at the time period that is the lowest, where we think a kid can be successful, and then we start shaping it up. So it goes from 5 minutes of focus on this assignment to 10 minutes, 20 minutes to 30 minutes. Last question.
One of the things I haven't heard you talk about and haven't heard often, but
Yeah.
have had success with as a parent, even up through college age,
Yeah.
was giving the subjects a 30,000-foot view of the plan ahead of time so that they understand the goal.
Right.
Where we might want to, what we might want to achieve, and then work backward
Right.
and talk them through it. It seems to help.
It's not necessary for the intervention to work, but it is very nice. We tend to do it as a matter of course for kids with middle school to high school age. Elementary schoolers, one of the issues we have when we present the interventions is they tend to react negatively. I don't want to do this. I don't want to have to earn stuff. I was getting Fortnite already. And then parents will get discouraged and say they believe the intervention won't work. So it's not necessarily a component that we require, but I agree with you. Wherever we can get buy-in, wherever we can preview it, I'm there. You got something to say, Cindy? Yeah. Hey, thanks.